you how to assess the symptoms related to heart disease in children. By listening to what the parents tell you, how do you reach a conclusion that this is the abnormal physiology that the child is having? And subsequently we will discuss what is the basis of the various physical signs that you elicit. We would start with dyspnea. Dyspnea can be defined as an unpleasant awareness of one's own breathing. Mind you, it doesn't necessarily imply that the breathing is fast. When the breathing is fast, you call it tachypnea. And since we deal with all ages of children, it is better to define at what age what constitutes tachypnea. In an infant or a neonate, it is different. In an older infant and older child, a sustained respiratory rate more than 40 per minute is tachypnea. The rate should be more than 60 if it's in neonates. Please remember, neonates normally tend to breathe fast for short periods and then slow down. That is their normal breathing. When you say that they are tachypneic, what you mean is that there is a sustained respiratory rate. And the causes for tachypnea, particularly in neonates, are more often respiratory than cardiac. So in small babies, don't jump to the conclusion that tachypnea or dyspnea necessarily denotes a cardiac problem. It may well be respiratory. But if it is cardiac, it has two implications to us. It could denote either left heart disease causing pulmonary venous hypertension or hypoxia. In the case of dyspnea, if the patient is becoming dyspneic when the patient is lying down, it is okay when he is sitting up. That is called orthopnea. What tilts the balance in a patient with a borderline compensated left heart disease is the increase in the venous return and decrease in the movement with the diaphragm. This in itself could be more dramatic if it is paroxysmal nocturnal dyspnea, which is the classical feature of left heart failure, not necessarily left ventricular failure. This occurs after a few hours of sleep. It is released in sitting position. And why does this happen? All the mechanisms of orthopnea are applicable here, but you should also explain why it is that the onset is delayed. This may be related to the different levels of sympathetic activity in different stages of sleep. You know that in REM sleep, the sympathetic activity is heightened, which causes peripheral vasoconstriction and an increase in the heart rate. Or during the NREM, particularly phases 3 and 4, there is a withdrawal of sympathetic support which matters to the heart in failure, and this could also be the reason for triggering cardiac failure. So if you look at the pathophysiology of dyspnea in some detail, there has to be a raised LA mean pressure. This means that either there is a left ventricular failure as a consequence of which the LV EDP is raised, or there is an LV inflow obstruction as a consequence of which raised LA mean pressure occurs. Example, myocinosis, obstructive PAPVC. And pulmonary venous hypertension, which in the case of PAPVC there is no LA mean pressure, it is directly pulmonary venous hypertension. But pulmonary venous hypertension leads to transudation of fluid in the interstitium. Now once the lungs are waterlogged, you need an increased respiratory effort to move the congested lungs. Not only that, you know there are J receptors in the interstitium which stimulate, if they are irritated, they stimulate the respiratory center. And as a result, there is an increased inspiratory effort without proportionate lung expansion. And this leads to intercostal and subcostal retraction. This is all in the context of left heart disease. But in the context of cyanotic heart disease, it's a very different ballgame. Hypoxia leading to acidosis and respiratory center stimulation. You know that dyspnea is graded. Most widely used grading system is that of New York Heart Association. The different grades are Class 1, diagnosed heart disease without symptoms. Class 2, dyspnea with ordinary activity like climbing 2 flights of stairs. And Class 3 is less than ordinary activity like walking in a room or in a corridor. Class 4 is the inability to perform any activity without dyspnea. If the patient puts one step forward and he becomes dyspneic, it is Class 4. Unquestionably, if he is dyspneic at rest, it is Class 4. However, this is very useful in adults. What about children, infants? It is very difficult to apply the NYHA concept of grading to small babies, and that's why the Canadian Pediatric Society evolved the ROSE grading of heart failure. Class 1 in ROSE is, of course, no symptoms. Class 2 is mild tachypnea or sweating which occurs with feeding. And in older children, if there is dyspnea on exertion, as in NYHA Class 2, it is ROSE Class 2 also. Class 3 is marked tachypnea or sweating while feeding, or in older children, there's like Class 3 effort dyspnea of New York Heart Association. And if they have a prolonged feeding time and failure of growth, they obviously fit into Class 3. And Class 4 is the real sick type with retraction, grunting, and sweating at rest. We often use the word feeding difficulty. What is the feeding difficulty, which is the main symptom of heart failure in infants? This results from dyspnea and fatigue while sucking. As the baby sucks at the nipple, this is an effort for the baby which triggers dyspnea through the mechanisms that we have already said. So it stops after a small feed. During this interim, there is dyspnea, fatigue, and forehead sweating. The baby rests for a few minutes and then starts sucking again, and this would be the suck, rest, suck cycle. When there is failure to thrive, conventionally we employ the term below 5 years. When the weight is below the 3rd percentile, or the weight for height is less than 2 standard deviations for the age, you say that the baby or the child has failure to thrive. The pathophysiology of failure to thrive is a little more complex. As you can imagine, a child with congestive heart failure will have feeding difficulty and consequently decreased caloric intake. The child with heart failure, with its heightened sympathetic activity, has an increased catabolism. The child with heart failure is also prone to recurrent respiratory infection, which we will discuss shortly, which again demands more energy which the baby is unable to provide. Plus, the systemic venous congestion is accompanied by portal venous congestion, which leads to anorexia and also decreased absorption from the gastrointestinal tract. The failure to thrive may also be part of a syndrome. One part of the syndrome is the heart disease, the other part of the syndrome is failure to thrive. So the two are not necessarily connected, except conceptually. For example, in Diego syndrome or rubella syndrome or Down syndrome, essentially there's a failure to thrive. Also remember, many of these syndromes have a reduced immunity which makes them prone to recurrent infection, and as we explain as we are discussing recurrent respiratory infection, there is an inherent low immunity in children with poor nutritional status. Now about recurrent respiratory tract infection, when do you say that there is a respiratory tract infection? Let us be sure of a few things. If a baby is getting episodes of cold, it has nothing to do with the heart. So let us never say that a baby has episodes of cough, cold. It is meaningless. But if a baby has episodes of lower respiratory tract infection, and these episodes are more than 4 to 6 per year, because any baby should be expected to have a few episodes of respiratory infection. So it is an increase in the frequency of that which will make you suspect that something is predisposed into it. If there are 2 episodes requiring hospitalization or IV antibiotics, then again you will be concerned and you will call it recurrent respiratory tract infection. So you need a lower respiratory tract infection, underline lower. This is commonly seen in post-tricuspid shunt, and the occurrence of these in post-tricuspid shunt is related to left heart failure and pulmonary venous congestion. When there is interstitial edema and pulmonary venodilatation, there is a compression of the bronchioles and retention of secretions. When there is pulmonary venous congestion, anastomotic channels could open up between pulmonary vein and bronchial vein, opening up and leading to bronchial mucosal congestion. The bronchial mucosal congestion and goblet cell hypertrophy leads to impaired mucociliary clearance. Dilatation of the left pulmonary artery compresses the left bronchus. Remember, the left bronchus is hyparterial, below the left pulmonary artery. So it is very vulnerable to compression, especially in infancy when it is short on cartilage. It results in retention of secretion and impairment of mucociliary clearance. And as I mentioned earlier, poor weight gain, poor nutritional status in children is associated with poor immunity, and this also predisposes to recurrent infection. This is all in the context of left heart failure. Remember, we have a different issue with hypoxia. With hypoxia, you have exercise causing systemic vasodilatation. Exercise increases the heart rate and the venous return. All these contribute to the right to left shunt. Take etiology. When the child is exercising, the right ventricle has the chance of ejecting across an obstructed infundibulum into the lung, or across a large VSD into an aorta where the systemic vascular resistance has dropped. So the increase in the heart rate increases the right to left shunt. The increase in the venous return gets shunted into the aorta. So as a result, you have all these things: systemic vasodilatation, the heart rate, the venous return, all contributing to an increase in the right to left shunt. Consequently, there is desaturation and acidosis. Both hypoxia and acidosis are stimuli to the respiratory center, and that causes tachypnea and dyspnea. This is the pathogenesis of hypoxia causing dyspnea. Now we move to another symptom, which is exertional fatigue. This is something which you should be careful in evaluating, because fatigue is something which people very casually use. But if there is a genuine exercise-related fatigue, it denotes inadequate skeletal muscle perfusion during exercise. And this is a feature of reduced cardiac output. Either the cardiac output is fixed at rest, or with exercise, there is no proportionate rise in cardiac output. This could occur either when there is a fixed RVOT obstruction, like in severe valve ARDS, particularly with suprasystemic RV pressures and right heart failure, or severe pulmonary hypertension, like primary pulmonary hypertension or Eisenmenger syndrome. So in these situations, the right heart is unable to increase its output. On the other hand, on the left side, any fixed LVOT obstruction, which is either valvar or subvalvar, could be the reason for the inability of the left ventricle to raise its output with exercise. And as a result, the muscles get inadequate blood supply and hence fatigue. A step further on is syncope. What is syncope? It's a transient loss of consciousness due to decreased cerebral perfusion. In this context, we are concerned more about exertional syncope, even though rest syncope itself is an issue. And exertional syncope denotes the inability of the heart to increase its output in the face of exercise-induced peripheral vasodilatation. That perhaps requires some explanation. When there is exercise, the skeletal muscles which are involved in exercise produce vasodilation. As a result, the peripheral vasculature is dilated. If the blood pressure is to be maintained, as you would know in ICU setting, in the context of a peripheral vasodilation, you need a greater volume. How does the body get a greater volume? The heart needs to pump, and the heart here is stuck. There is either an LVOT obstruction or an RVOT obstruction or severe PAH, hence the heart does not increase its output. So which means that in the phase of peripheral vasodilation, the heart cannot increase its output, and hence the brain suffers, hence syncope. A few other mechanisms may also be involved with exercise, particularly in aortic stenosis. Mechanoreceptors in the LV myocardium are stimulated, and they trigger a Basalt-Jarisch reflex. Remember, a Basalt-Jarisch reflex is essentially a stimulation from the vagal nerve ending that is reported with the right coronary artery, as a result of which there is profound bradycardia and hypotension which are vagally mediated. So the stimulation of the mechanoreceptors in the left ventricular myocardium could be also a reason for the syncope in aortic stenosis. Remember, in these diseases which are major diseases, there could be an arrhythmia which may be triggered by exercise. So these three factors are responsible for syncope in the context of a fixed cardiac output. And the causes, I'm just presenting the concept, it is either severe pulmonary hypertension or severe LVOT obstruction. The list would be very long. Syncope at rest is no less significant, only thing is it is a little different pathophysiology. Positional syncope is a feature of left atrial myxoma. Like when a patient shifts from one position to the other, the myxoma, which is not obstructing earlier, gets a chance to obstruct the LV inflow, and as a result, the patient develops syncope. Also, unrelated to position, unrelated to exercise, syncope occurs in the context of complete heart block or sick sinus syndrome, where there is a profound bradycardia. This is what is called, in the context of complete heart block, classically it is referred to as a Stokes-Adams attack, and during the Stokes-Adams attack, either there is extreme bradycardia or actual asystole or ventricular fibrillation. You could also have vasovagal syncope or neurally mediated syncope, perhaps the commonest cause of syncope in children, and which is harmless, which say when a child has been standing in school assembly in sun, the child drops down unconscious and an anxious mother brings the child to you. This tends to disappear as the children grow older. So, there's a frightening site which is triggering the syncope, or it may be site of blood, it may be pain. These things could trigger syncope. Yet another symptom that we consider significant would be palpitation. It is an unpleasant awareness of one's own heartbeat. Again, mind you, we haven't said that it is necessarily tachycardia. An unpleasant awareness of one's own heartbeat could be exertional, it could occur at rest, or it could be paroxysmal. Accordingly, there is some difference in the implication. Exertional palpitation is a sign, is a symptom of volume overloading in the heart, either right side or left side. On the right side, the typical example is atrial septal defect. On the left side, either mitral regurgitation or aortic regurgitation. Palpitation at rest may be due to volume overload or arrhythmia. This is the example where a patient with mitral regurgitation again may turn to the left side while in bed and suddenly feel the palpitation, as now the apex beat is closer to the chest wall. Palpitation at rest may also be due to arrhythmia, when it could be a paroxysmal palpitation. What we mean by a paroxysmal palpitation is that there is a fast heart rate which is abrupt in onset and which is abrupt in offset. That is always abnormal. And here, the maximal heart rate is achieved in a single beat time. 1 beat ago, this patient had a heart rate of 70 or 80, and 1 beat later, the RR interval corresponds to a heart rate of 200 plus. a feature of paroxysmal palpitation in children more often HVT. During an episode of HVT, there may be polyuria, and the child or the parents might notice inadvertently that a vagotonic maneuver like straining a stool or gulping down cold water may terminate the palpitation, because these are vagal stimuli. So paroxysmal palpitation is abrupt in onset and offset, where the maximal heart rate is achieved in a beat's time. You may notice neck pulsations, and a vagotonic maneuver may terminate it. Yet another symptom is chest pain. Chest pain in children is seldom cardiac in origin. This is important to remember, because it is extremely common for anxious parents to bring a child who complains of some pain somewhere in the chest, and if there is an ECG in their hand. It is extremely unlikely that it is anything significant. But I tell parents that look at the types of contortions that a child goes through in its normal physical activity. Try doing it yourself and imagine what pain it will cause you. And it is no surprise that the child does get chest pain from time to time from its normal activity. So most commonly, chest pain in a child is not cardiac. But when it is actually cardiac, the common reason may be pericarditis. Far less commonly, a coronary abnormality like an anomalous origin of the left coronary artery from the pulmonary artery may be responsible for an ischemic chest pain. Also, abnormal course of the coronary artery, say a left coronary artery which is traversing between the aorta and the pulmonary artery, during exercise may get compressed and could be a reason for ischemic chest pain. Acquired causes where there is a coronary artery involvement in a child, like a Kawasaki's disease or Takayasu arthritis, may also be a reason for chest pain in children. These are all related to coronary artery. But in the context of Eisenmenger syndrome or aortic stenosis, you may have a different mechanism for chest pain. There is an increase in the left ventricular or right ventricular muscle mass without a proportionate increase in the capillary density. As a result, with exercise, there is a myocardial ischemia causing chest pain, fairly common in both Eisenmenger syndrome and LVOT obstruction. And when it occurs, it denotes an adverse prognosis. Mitral flash is commonly linked to chest pain. More often, this is imaginary. You make a diagnosis of mitral flash and you call a non-cardiac chest pain in a child or an adult as related to mitral flash, and thereby giving the idea to the patient that chest pain is something very important. So be careful when you attach significance to the occurrence of a vague chest pain in a patient with mitral flash. You have other symptoms like edema or facial puffiness. They denote systemic venous hypertension. Remember, in an infant, edema is very less likely because the baby is generally lying down, so it is likely to manifest more as facial puffiness, and more readily you may recognize an enlargement of the liver. So the cause of edema and facial puffiness is congestive heart failure. Severe tricuspid regurgitation, it may occur with postoperative right ventricular dysfunction like intracardiac repair for tetralogy, or severe pulmonary arterial hypertension and tricuspid regurgitation may be a cause. Now we move to another important symptom, which is cyanosis. Cyanosis is both a sign and a symptom. It's a symptom when the patient complains of it. It's a sign when you elicit it. Cyanosis, as you know, is a bluish discoloration of the skin and mucous membrane due to increased concentration of reduced hemoglobin, which is, if it is more than 3 grams in arterial blood or more than 5 grams in capillary blood, it is associated with cyanosis. And remember, cyanosis, even though very commonly cardiac, could be due to abnormalities of other systems, and this is particularly important in neonates and small babies. It could be a neurologic problem in that there is a central hypoventilation causing the baby to be cyanosed, It may be musculoskeletal. The child's chest wall is not moving well enough for adequate air exchange to occur. It may be because of an airway obstruction. It may be because the alveolar capillary membrane is thicker than usual. It may be because of an abnormal hemoglobin. It may also be because of the heart. So in a neonate, when you are called in to assess the cause for cyanosis, remember that the cyanosis may well reside in other major systems. The other way to look at cyanosis is to see whether it is central or peripheral. Central cyanosis is noticed in the central parts of the body, like the lip, the tongue. It is also seen in the periphery. But peripheral cyanosis is noticed only in the periphery. And the peripheries are cold when there is peripheral cyanosis. So the distinction of central versus peripheral is mainly, are the peripheries cold? Simply in neonates and small infants, exposure to cold itself may be a cause for peripheral cyanosis. In older children and adults, it is generally associated with shock. When there is hypotension and there is peripheral vasoconstriction, that may be the underlying factor for cyanosis. Yet another distinction that you need to make, particularly in small babies, is whether the cyanosis is cardiac or respiratory. The rule of the thumb is, if the child is peacefully cyanosed, meaning you find that the baby's saturation is 70%, but the baby looks very comfortable, that is cardiac cyanosis. The logic is, if a respiratory reason is responsible for cyanosis, you expect respiratory distress. So if there is obvious respiratory distress, as in a pneumonia or a bronchopneumonia, there would be cyanosis, but the child would be distressed. But in a tetralogy of pulmonary atresia, where the saturation is 40%, you may find that the respiratory rate is fast, but the baby looks otherwise comfortable. Remember, in conditions like an obstructed PVC, these two situations merge, where there is a cardiac cause for cyanosis, but there is a respiratory cause, pulmonary edema, for the respiratory distress. So, even though these guidelines are generally useful, you must also apply your judgment in assessing when different situations are combined. In the older child with cyanosis, clubbing is readily made out. What is clubbing? It is an obliteration of the angle between the nail and the nail bed, and it is accompanied by an increased fluctuation of the nail bed. If you are following a baby with cyanosis, this tends to appear by 6 to 7 months, and it appears first in the thumb. Why does clubbing occur? We do not know the actual reason. One of the most widely held theories is that the megakaryocytes, the platelet precursors, which would normally get filtered in the lung, if they do not get an opportunity to enter the systemic circulation, given a large intercirculatory communication, they reach the peripheral circulation. And once they are circulating in the peripheral circulation, they cannot negotiate small capillary beds like that in the nail bed. So they get sequestrated there. And these sequestrated megakaryocytes undergo degranulation, releasing their growth factors, and these growth factors promote both new vessel formation and new tissue formation. Hence, you have the fluctuant tissue at the base of the nail, and this is the trigger for clubbing. It's a very attractive theory, and this is perhaps the most widely held theory. When you evaluate the cyanotic patient or the cyanotic baby, there are certain things that you need to do. I would particularly highlight how you look at the cyanotic baby, because there your assessment would be life-saving. The first question is the baby cyanosed? In the modern day, we don't debate about it, we check the SpO2. Once the SpO2 is low, you see whether the cyanosis is central or peripheral. If you keep the baby warm, this issue is simpler. The periphery will not be cold, so you can easily make out whether a drop in SpO2 is due to a central or a peripheral reason. Then the next question is the cyanosis cardiac or respiratory? Two things. I already referred to the peaceful cyanosis of cardiac origin. There, the respiratory distress when the cyanosis is respiratory in origin, plus response to oxygen is also useful. While speaking of response to oxygen, please remember that in any cyanotic heart disease, if you give the baby oxygen, there will be some increase in the saturation. You could expect maybe 10 to 20 percentage points increase in the saturation. This is not what we are meaning here. We are referring to the hyperoxia test in the newborns, where you administer 100% oxygen for 10 minutes and do an ABG before the start of the test and after 10 minutes. If the initial ABG showed a low PO2 and the second ABG showed that the PO2 rose by more than 300 millimeters of mercury, obviously the heart is not at fault. It has to be a respiratory reason. On the contrary, if the PO2 in response to oxygen is less than 150 millimeters of mercury, the cyanosis is very likely to be cardiac. Between these two extremes, you enter a gray zone where you have conditions like obstructive CAPVC, where you will find a value right somewhere in between. This is because there is a cardiac contribution, there is a cardiac major contribution to the cyanosis, but the lungs are also involved because of pulmonary edema. So you get a value in between. In the absence of a respiratory reason, if you check the arterial blood gases in a baby with cyanosis, for example, Cyanotic pulmonary atresia, you will find that the PO2 is low, that the pH is low, and the PCO2 is low also. pH and PO2 for obvious reasons, and PCO2 because the alveolar capillary membrane is normal, the baby is tachypneic, so the baby would wash out carbon dioxide. So that is the expected arterial blood gas in a pathology type. Before you do an echo, you are likely to get an X-ray and an ECG. The heart size and the configuration, like the typical the snowman appearance or the figure of 8 appearance in the KPVC or the Agon side appearance in the GGA, these things are useful. More usefully, I would say, if you look at the vascularity, if the PO2 is low and if the vascularity is low, you are dealing with a pathology like this situation. If the PO2 is low and the vascularity appears increased, you are dealing with a TGA-like situation. The ECG could be useful in the pathology pulmonary atresia. You expect a right ventricular hypertrophy and an RV dominance. In a tricuspid atresia, you expect a left ventricular hypertrophy and an LV dominance. And cyanotic internal heart disease, you must have some idea of how to approach it. So the reduced pulmonary blood flow situation is classically pathology and pathology pulmonary atresia. A number of complex congenital heart diseases where there is a large VSD and an obstruction to pulmonary blood flow, we call it as pathology like physiology. Again, some other class we would discuss this. Basically, if you have a large VSD and there is an obstruction to the pulmonary flow, it will behave like pathology. In a different situation, in a critical pulmonary stenosis or pulmonary atresia with intact ventricular septum, there is pulmonary edema. There is either very little blood going into the lung or none going into the pulmonary artery, and the pulmonary arterial flow is dependent on a duct, and this patient will have pulmonary edema and cyanosis. The neonate with extreme is also has a reduced pulmonary blood flow because the dysfunctioning small right ventricle cannot pump against the heightened pulmonary vascular resistance of the newborn. Hence, in extremes anomaly, you tend to get cyanosis. In the older child with extremes anomaly, either when there is RVOT obstruction or due to the inadequacy of the functional RV, there is a right-left shunt across the ASD, and that is the reason for cyanosis. So the common features in the reduced pulmonary blood flow group: low PaO2, X-rays showing oligemic lung, and in the case of a neonate, response to prostaglandin. If you start prostaglandin, the saturation improves. And remember, this is all cyanotic congenital heart disease with reduced pulmonary blood flow. Now to go to the other end of the spectrum, increased pulmonary blood flow. If you have transposition of the great artery, or if you have total anomalous pulmonary venous connection, or a single ventricle, or truncus arteriosus, or a double outlet right ventricle with a large VSD, or an aortopulmonary window, these are all conditions where there is cyanosis, heart failure, cardiomegaly, a generally unimpressive murmur, and a chest X-ray showing increased vascularity. So, a child with cyanotic congenital heart disease and increased pulmonary blood flow has features of cardiac failure combined with cyanosis. They usually have severe failure to thrive. In this context, some specific situations in cyanosis are also worth recalling. One of the most dramatic things that happens to a child with cyanosis and reduced pulmonary blood flow is a cyanotic spell. A cyanotic spell is a rapid decrease in systemic oxygen saturation accompanied by hyperventilation. Mind you, there are two defining features. There is a rapid, I would say dramatic, decrease in the systemic oxygen saturation. Before your eyes, the saturation seems to drop from 60 or 70 to 10 or 20. This is accompanied by hyperventilation. And if you don't intervene urgently, the baby goes into convulsions, coma, or death because there is progressive cerebral hypoxia. So these two features, the progressive hypoxia and hyperventilation, would define a cyanotic spell. It's classically seen from 6 months to 6 years. Remember, when a baby has cyanosis on crying, it is not a spell. Every baby with some cyanosis, the cyanosis will worsen if the baby cries. This doesn't have the implication of the cyanotic spell, even though the crying can actually trigger a spell. That's a different factor. So remember, when you are eliciting history, getting the history of hyperventilation and bluish discoloration, going on to a limp state of the baby or convulsion. That is what tells you that the baby was having a cyanotic spell. Why should a child with pathology develop cyanotic spell? The right ventricle in pathology has two outlets. It can eject across the infundibulum, which is obstructed, into the pulmonary artery, or it can eject across a large VSD into an overriding aorta. Given this choice, at any given point in time, what the right ventricle chooses to do is largely decided by the systemic vascular resistance. The RVOT obstruction is fixed, so the variable component is the systemic vascular obstruction. Plus, in the young infant, the infundibulum has not become fibrous and it may be liable to get infundibular spasm. So a drop in the systemic vascular resistance or infundibular spasm encourages the right ventricle to pump more into the aorta. We have already described what happens when there is a greater right to left shunt. The greater right to left shunt means the systemic oxygen saturation is dropping. It also means that there is acidosis because when there is hypoxia, the tissues need to work under anaerobic circumstances. So as a result, lactate is produced and there is acidosis. So a greater right to left shunt means a drop in saturation as well as acidosis. And remember, both these can stimulate the respiratory center. And the respiratory center responds by hyperventilation. Normally, when a person runs, he is hyperventilating. When he is running and hyperventilating, there is also an increase in the pulmonary blood flow. Therefore, the hyperventilation is with a purpose in increasing the oxygen exchange which is occurring in the lung. Does this happen in pathology? It cannot, because as the lungs are being inflated and deflated, as the respiratory muscles are moving more, the blood flow into the lungs, if anything, is reduced, not increased. So this is something bad. The hyperventilation is not something that is helping the child. It is something which is going to worsen the child, because the respiratory muscles are essentially skeletal muscles and they are being overactive under a hypoxic setting, thereby contributing more to the acidosis. That is why this becomes a vicious cycle. So what we said, the drop in the systemic vascular resistance and or the infundibular spasm worsens the right to left shunt, worsens acidosis and hypoxia, triggers hyperventilation. Hyperventilation doesn't help, but it actually harms the child, thereby setting up a vicious cycle which is broken if only you intervene. If you look at this picture, this actually presumes that infundibular spasm is a major factor, which is not true. The systemic vascular resistance is equally or even have a greater importance, but as a cartoon, this is useful. Note the large VSC and the right ventricle pumping into the aorta and also across the obstructed infundibulum into the PA, and during a spell, as the flow through the pulmonary artery decreases, there is even a greater flow into the aorta of the desaturated blood. Something similar in older children will be squatting. We said that cyanotic spell is something that occurs between 6 months to 6 years. What happens beyond 6 years? The children learn to squat. During exercise, they realize that squatting can relieve effort dyspnea, and therefore they don't go on to develop a spill. How squatting helps is, we know how exercise worsens the hypoxic state. Squatting has important hemodynamic effects by working on the femoral vein, the femoral artery, and by compressing the abdomen. On the femoral vein, the abrupt squatting is stinging the femoral vein, and the most desaturated blood is from the lower limbs when you are exercising. So this desaturated blood is locked up in the lower limbs. It also stings the femoral artery. When the femoral arteries are stinged, there is an acute increase in the systemic vascular resistance. Remember, it was the drop in the systemic vascular resistance which is encouraging the right ventricle to pump into the aorta. So an increase in the systemic vascular resistance is a disincentive for the right ventricle to pump into the aorta. Also, the process of squatting involves an abdominal compression. Having locked up the desaturated blood in the lower limbs, if you can compress on the abdomen and displace the splanchnic blood, which is much better saturated, into the heart, even though there is a right to left shunt, what is shunting right to left will have a better oxygen saturation than from the lower limb blood. In other words, the splanchnic blood, where the oxygen extraction is less, it is the viscera, if that is returning more to the heart, even the right heart will have a better oxygen saturation, and even though there is a right to left shunt, you will find better saturation. So these three mechanisms, stinging the femoral vein, stinging the femoral arteries and increasing the systemic vascular resistance, and displacing the better saturated mesenteric venous blood into the heart, are responsible for the relief that a baby has, a child has for cyanosis and exertional dyspnea with squatting. It is also worthwhile recollecting cyanosis in certain special situations. We often use the word differential cyanosis. What is differential cyanosis? It is cyanosis more in the lower limbs and often associated with fluffing. It is classically a feature of Eisenmenger syndrome in PDA, and this happens because in PDA, when the pulmonary vascular resistance increases, the PDA starts shunting right to left so that the descending aorta is getting a blood of lower saturation, while the ascending aorta is getting a blood of higher saturation as it is coming from the left ventricle. So, as Eisenmenger syndrome develops in a PDA, the child is likely to be in the second or third decade. By the time clubbing would also be seen, you can notice a young individual who has cyanosis and clubbing which is pronounced in the lower limb and which is absent definitely in the right upper limb, maybe borderline in the left upper limb. That is differential cyanosis. In a newborn with persistent pulmonary hypertension, you can see the equivalent of this by monitoring the SpO2 in the upper limbs and lower limbs. In a PPHNS in the newborn, the right to left shunt ensures that the lower limb saturations are low, so you notice a difference between the upper limb and the lower limb saturation. The situation of differential cyanosis can be reversed if the heart is not normal but is having PDA. In this case, what comes through the duct is at a better saturation, and therefore you will find higher saturations in the lower limbs. So if you had a transposition and a coarctation with a PDA, this is not an impossible combination because coarctation has a greater association with PDA, and certain PDA like physiologies like toxic wing may have as much as 30 to 50% association with coarctation. So this is not an unusual thing to happen in pediatric practice in very young neonates and infants. So if you have a PDA and a coarctation and a PDA, it is a lower limb which has better saturation, the upper limbs have a lower saturation. A somewhat different situations that you will see, you have examined the heart, it looks normal to you, but this person is cyanosed. This happens in pulmonary AV fistula. The heart itself is normal, but in the lungs there is a right left shunt, and as a result, the person is cyanosed. In some of the systemic venous anomalies also this can happen. If the inferior vena cava is draining preferentially into the left atrium, tends to occur with an IVC type of ASD, or the superior vena cava is draining into the left atrium, you will get a cyanosis with no obvious cardiac reason for that. Thank you. I would welcome any questions.
Dr. Suresh, thank you. That was great. I see 3 questions from Narayana.
I will answer them. I will answer them.
Great.
The first question is, what is the mechanism of dyspnea in pulmonary stenosis? If you mean valvar pulmonary stenosis with an intact ventricular septum and RV pressures which are even systemic, there is usually no symptom. I always remind students of a sentence in the old textbook of cardiology by Paulwood, in which Paulwood said that his patients with severe valvar pulmonary stenosis included a New Zealand Test cricketer, a 4-mile runner, and 2 other people of comparable effort tolerance. Therefore, in valvar pulmonary stenosis, effort dyspnea usually does not occur. When it occurs, there are 2 or 3 things that is happening. One, you have an older child or an adult with what I would call neglected valvar PS, where you have suprasystemic right ventricular pressure, you have a right to left shunt across a PFO. In such a setting, the hypoxia is responsible for the tachypnea. This can occur. So also, if you find the very young neonates with critical valvar PS and profound cyanosis, that baby is cyanosed because there is a right to left shunt across the PFO or an ASD, and that is the reason for cyanosis, and this hypoxia is a reason for tachypnea. But I would like to highlight the Paulwood quotation that dyspnea in valvar PS is more often imagined. There's one more question, let me just take it. this Trachis Pathophysiology, Fallows Physiology, I haven't followed. What exactly would you like to know? Can you either ask me or type it? And yeah, there is a question as to whether is AP Lindo cyanotic congenital heart disease? No. AP Lindo is just like VSD. It is just at the, or like PDA. It's just that the communication is at the aortopulmonary level. So unless the patient goes into an Eisenmenger state, it's not cyanotic heart disease. And what is the mechanism of exertional palpitation? Okay, well, let's take a patient with mitral regurgitation. A patient with mitral regurgitation has a greater stroke volume. This the person at rest has got used to. During exercise, this increase in the stroke volume becomes more striking, and remember, palpitation is an awareness of one's heartbeat. So the more forceful contraction of the heart, which if the person has not noticed at rest, becomes evident on exercise as the rate increases and as the force of contraction increases further. Is Trachis Pathophysiology Fallows Physiology? It's a little gray area. See, in the case of Trachis Pathophysiology, what causes cyanosis is the obligatory right to left shunt at the atrial level. That way, you cannot consider it Fallows physiology. But when the patient is presenting to you, what you see is a 1-year-old child with cyanosis. The child has cyanosis worsening on exercise. Spells usually do not occur, but if spell occurs, that is a worsening of cyanosis which is occurring in a child with a closing BAC. So it has some overlapping features with pathology of Fallows, but their essential physiology is different from pathology of Fallows. I would like to confine the word pathology like physiology to those conditions where there is a large BSC, obstruction to pulmonary blood flow, and the relation between these two is responsible for aortic desaturation. I think any follow-up on those questions?
Dr. Suresh, one more question. Can you spell in pulmonary atresia? I think a lot of people put pulmonary atresia VSDs on Inderol.
Yeah.
So this question often comes up.
I do not think there is a spell in pulmonary atresia, because the one thing that can happen is some drop in saturation in pulmonary atresia definitely occurs with exercise, because whatever is on the resting state, with exercise you find a greater right-left shunt. But an actual spell in pulmonary atresia is very unlikely, and if you have a neonate with rapid decrease in saturation in a pulmonary atresia, that is because of a constricting touch. Personally, I do not believe that propranolol is of any great use in pulmonary atresia pathology. But some drop in the heart rate might help a few people, and this may be the logic with which people prescribe it. But my own personal practice is not to use it.
Thank you so much, Dr. Suresh. That was a fabulous class. So I will send the recording out to everybody, and we'll see you on Thursday with the signs. And then for the postgraduates, Dr. Suresh sir will also do next Tuesday. The signs will be done over 2 classes. So on Thursday followed by Tuesday. Thank you very much.
Bye.